Good day everyone, I'm Shivaani. Today we'll be looking into a complex case. Our case today is mainly about oral manifestations of diabetics. Our patient is a female in her late 50s. Her chief complaint was pain on lower right back tooth for the past 7 to 8 months, and her last history of pain was last night. Patient is on antihypertensive medications. Her last reading was 150 by 90 mmHg. Even though she's on her hypertension medications, it's still poorly controlled. She also has diabetes, where she's taking metformin and insulin injections. Her last fasting blood sugar reading was 13 millimole per liter. Her diabetes is also poorly controlled. Patient also has a history of penicillin allergy, and the following will be her dental history. Moving on to the HOPI, patient complained that the pain appeared suddenly and was moderate for the past 7 to 8 months. The pain became severe last night. The pain lasts for 10 minutes, and the patient described the pain as a throbbing kind of pain. She also complained of severe headache, and her entire right jaw was in pain. Sensitivity could be felt on the associated tooth. Swelling was also noted by the patient 2 months ago. Pain aggravated during her sleep. To relieve the pain, patient kept clove on her tooth. Patient also took painkillers and antibiotics. An attempt to extract the tooth was initiated, but was forfeited due to severe pain and failure of LA. The VAS score was 10 out of 10. The additional complaints were also stated by the patient, where she can't tolerate spicy food, and also complaints of burning mouth. Upon general extraoral examination, patient's facial was symmetrical. Her lymph nodes were non-tender and non-palpable. There weren't any deviation or clicking could be seen or felt on the temporomandibular joint upon mouth closing or opening. Under general intraoral examination, under hard tissues, the number of teeth present were 23 and the number of teeth missing were 9. The ICDAS coding for each tooth that had dental caries were noted. 4 teeth were mobile, that was categorized under grade 1 and grade 2. Patient also had supraeruption and abfraction. Under soft tissue, a solitary white ulcer on the lower labial mucosa could be seen. Mixed white and red lesion could be seen on the left side of buccal mucosa. On the dorsum of the tongue, a deep papillated atrophic area could be seen, whereas on the lateral surface of the tongue, a mixed white and red lesion could be seen. On the palate, a tori was present. Patient also had generalized periodontitis. After general examination of the oral cavity, under hard tissue it was found that tooth number 47, 38, and 36 were our tooth of interest. The ICDAS coding for each of the tooth were recorded. To see whether tooth was tender on palpation or non-tender, or whether it was tender on percussion or non-tender, it was carried out and was noted as well. One of the soft tissue lesions that we found was on the dorsum of the tongue. Based on the picture on inspection, a 2 by 3 cm of deep papillated atrophic area at the center of the tongue, anterior to the circumware papillae, could be seen. There isn't any effect on the surrounding tissue. Upon palpation, it is non-tender. The diagnosis will be median rhomboid glossitis, and the differential diagnosis is atrophic glossitis. The next lesion was also found on the tongue, but at the left lateral surface. On inspection, an irregular mixed white and red lesion, about 2 by 1 cm in size, was found. It was in close proximity to the floor of the mouth. The surrounding area looks erythematous. On palpation, it was non-tender, and the diagnosis were erythemaceous candidiasis, and the differential diagnosis were speckled leukoplakia. Our third lesion of the soft tissue was found on the left buccal mucosa. Upon inspection, there was an irregular mixed white and red lesion about 2 by 1 cm in close proximity to 3/8 that we could clearly see in the picture. The surrounding area also looks erythemaceous. Upon palpation, it was non-tender. The diagnosis will be erythemaceous candidiasis, and differential diagnosis were speckled leukoplakia. Under chest-side investigation, the left buccal mucosa was scraped to see whether it was scrapable or non-scrapable lesion. It was a scrapable white area about 0.3 cm. There was also white specks of food debris found. Our provisional diagnosis for the depapulated area on dorsum of tongue would be median rhomboid fasciitis, whereas the mixed white and red lesion of the buccal mucosa and left lateral surface of tongue would be erythemaceous candidiasis. The differential diagnosis for both would be atrophic glossitis and speckled leukoplakia. The prognosis is also good. So upon taking an X-ray for all three tooth of interest, in the first radiograph we could see 4-7 where there is a deep secondary caries involving the pulp with localized periodontitis with condensing osteitis. The differential diagnosis could be hypercementosis as well as sclerosing osteitis. The second radiograph shows radiographic diagnosis of 3-6 and 3-8 where deep dental caries involving pulp, localized periodontitis with condensing osteitis, and the differential diagnosis is same as the first radiograph. The following will be her treatment plan. Step 1 was the most important treatment for her, where she was made aware of the need to control her diabetes, followed by extraction of 4-7 and 3-8. She was also prescribed medications such as candid mouth pain, clotrimazole, thymol of 0.05% to be used twice daily, Bonjela, where the contents are stated, to be applied on the affected area, followed by scaling and denture fabrication. On the first week of follow-up, patient's blood glucose level was still very high. It was at 20.9 millimole per liter. Her blood pressure was at 130/80 mmHg. Patient was given paracetamol tablets, 500 mg, twice a day for 3 days. She was given a referral letter for evaluation by physician. On the second week of follow-up, her insulin injection unit was increased by a physician. Patient also claims that her burning sensation has reduced after using the thymol mouthwash. Patient's blood sugar level is still poorly controlled where random blood sugar was 15 millimole per liter. Patient was advised on a high glucose level and to get a clearance letter from a physician. It has been found that an individual with uncontrolled diabetes presents a higher risk of infection as well as abnormal prolonged healing time that will endanger the health of the oral cavity. Research has established that patients with diabetes mellitus may present a variety of oral manifestations. The chart below shows the pathophysiology of diabetes and dental diseases. These are the few pictures where uncontrolled diabetes is reflected in the oral cavity. The first picture shows the effect of uncontrolled diabetes on periodontium. Diabetes does not cause periodontal disease directly, but it alters the response of periodontal lesion to local irritants, hastening bone loss and retarding post-surgical healing of the lesions. The second picture shows multiple periodontal abscesses. A periodontal abscess can develop in a non-diabetic patient as well, but in a diabetic patient, the development of the abscess is more rapid, severe, and painful. The periodontal tissue develops resistance and reduction of tissue immunity. The rapid progress of periodontal abscess with much destruction of tissue is due to the excessive sugar content in periodontal tissue in a diabetic patient. The third picture shows severe dryness in the mouth. Dryness is associated to reduction in the rate of salivary flow. It is also associated with parotid gland enlargement in diabetic patients. Parotid gland enlargement may be due to cellular hypertrophy of the gland as it has to overfunction to produce saliva, as saliva is decreased in diabetic patients. Fourth and fifth picture is oral candidiasis in different locations in the oral cavity. It is an infection caused by Candida albicans. Dry oral mucosal surface is favorable for the penetration of Candida albicans, causing the disease to process. As the tissue contains more glucose, it lowers tissue resistance and Candida can easily affect the tissues, producing candidiasis. In diabetic patients, they will develop pseudomembranous candidiasis, either chronic or acute. Clinically, multiple curd-like white patches develop because of the precipitation of tissue proteins by the candidal infection, and this white patch is scrapable. On eliminating the white patch, the area is erythematous and produces a burning sensation. The sixth picture shows a depapillated atrophic area in the midline of the tongue, where it is a median rhomboid glossitis. The frequency of abnormal blood sugar level in diabetes patient is much related to the occurrence of median rhomboidal glossitis. There is also impairment of blood supply to the dorsum of the tongue due to atherosclerotic changes in the blood vessels supplying that area. These are my references, and thank you.